Welcome back to our second episode of Specialties in Medicine podcast, or as we informally like to know it, SIM podcast. My name is Justin Lee, and I'm here with Dr. Sundip Patel. He is a board-certified emergency medicine physician, and he is an assistant professor of emergency medicine at Cooper University Healthcare System, and he is also a clerkship director for that program as well. He received his MD from UMD&J Robert Wood Johnson Medical School, and he continued on with his internship and residency at Cooper. So I see you've been in Camden for quite some time now. Is that correct?
That's correct. About 13 years, 15 if you count the 2 years clinically I did as a student.
So what initially drew you to Camden?
The people. There's just a wide variety of diversity of patients, many different ethnicities, whether it be Hispanic, African American, Caucasian, Vietnamese, and that they're really sick. They really need our help. So I think that was just a big draw.
And are you originally from an inner city area like this?
Well, I'm from South Jersey, so I guess that's the other draw that was here. This is not too far away from home, so it's kind of, in my mind, I'm hoping we're giving back to the state. But just naturally, I like this area, I love being in this area, so I think it was just made sense to come here to Cooper.
A natural fit, I see.
Mm-hmm.
And may I ask, where you started with your undergraduate, or were you also in the area for undergraduate?
Yep, I went to Villanova University, which is not too far away from here. So really have been really local with high school, college, med school, residency, and now my job. So yeah, I've just kind of stayed in this area.
That's great. And may I ask what you studied in undergrad?
Chemical engineering.
Oh, that's great. So
yeah, definitely different than what I ultimately wound up in.
Yeah, for sure.
But the ultimate goal was to go into medicine. I was just kind of fascinated by chemical engineering, and a lot of the requirements for chemical engineering were very similar to the requirements if you were a bio major or physics major. So it seemed to me, why not?
Kind of universally fit, that scientific background.
That's correct, yeah.
And at what point did you begin to know you wanted to practice medicine?
Before getting to college, I would say, in high school I was definitely entertaining it, and it's actually what led me to volunteer at a local hospital, and they actually put me in the ER, and that's probably where I got my first taste of emergency medicine, and probably where I got really interested in it.
That's great. Do you feel like you still are enamored that same way from when you were first volunteering in an ER?
Oh yeah. It's an amazing job. We get to do some really cool things. It sounds cliche or hokey, but you do get to save lives in emergency medicine. No matter how bad the shift could have been, you walk away and you can really feel that you made someone's life better. A couple of cases where maybe they're in a lot of pain and you're able to relieve that pain. They're really short of breath and you're able to fix that. Mm-hmm. So even on your worst shifts, I think you can easily point to a couple of cases where you made someone better.
And while you were in medical school, were there any particular experiences or influences that kind of drove you towards this field?
So that's a good question. When I went to med school, the curriculum was a lot different than it is now. You didn't have as much clinical exposure to patients as I think most schools do now towards students. So you kind of had to seek out some experiences. So I think one of the biggest influences was the Emergency Medicine Interest Group. Or the EMIG group. It's where you got to go talk to fellow students that were interested in emergency medicine, your upper levels that had some experience, and then they would bring physicians down. And actually, the current program director, Dr. Andrew Nice, that's where I got to meet him for the first time, as he had actually driven 70 miles out of his way on his own time to come talk to us and show us what emergency medicine was about. So I think that was a big influence.
I can imagine how great it is to have someone come to your school to lecture if you don't actually have those resources available.
Mm-hmm. And those resources were up there, but it was just a good example of him just kind of spending his time to kind of help us out, as first and second year students.
Yeah. And what other specialties were you considering at that time while you were in school?
That's a good question. I went into it thinking I want to do emergency medicine, so I'm in a little bit of a different, I think, starting point than some students, but I kept an open mind. So all throughout my third year, I looked at all the clerkships and other specialties and just tried to figure out would it fit my personality, what I wanted to do. And what I quickly realized is I liked a little bit of everything. And I think that's where you kind of figure out that, emergency medicine might be a good career because that is what we do. We kind of do a little bit of everything. So there wasn't ever a thought like, I got it down between emergency medicine and radiology, or emergency medicine and internal medicine. It was just going through all the clerkships, you pick up things that you really, really like, and then I found that, emergency medicine encompassed a lot of them.
And currently in your practice, would you be able to describe what your patient population is like on a daily basis?
Mm-hmm.
What kind of patients do you typically see here in the inner cities?
Sure. And I think whether it's the inner city or whether you're out in the community, there's going to be some differences or variances, but I think ultimately you're going to see a patient of any age show up to your door. So you can have a 6-month-old show up to the emergency room all the way up to a 102-year-old. And I think that's one of the beauties of the field is you get to see it all and do it all. Obviously, any type of ethnicity will show up. I can't tell you how many times during a shift I may have to get a translator to help me. So, if someone's speaking Vietnamese, you need to somehow figure out a way to communicate with them and figure out what's going on. So you have to kind of figure that out in terms of different interpersonal communication styles, different interactions, different cultural beliefs. And so you'll see many, many different things. You're going to see patients that may just come in by themselves, patients that will come in with like 4 or 5 family members. So you're really going to see a whole wide variety and gamut of people that will show up at the front door.
You had mentioned in the past, or even just now, the diversity of patients that you see, and you said that this may have been one of the driving factors that draws you to more of that inner city hospital setting. What other priorities and determinations went into considering emergency medicine? Was it family, the lifestyle?
So, for me, it wasn't exactly lifestyle. And then, I think we can talk about that a little bit more because I think if you get into emergency medicine just for the lifestyle, then you're going to get into it for the wrong reasons. And then I think the people that do that are the ones that will get burned out or try to leave the field early. If they see like, oh my God, you're not working as much or you're not on call, and that's the only reason you get into this job, then I don't think you'll last long. And I don't think those are the right reasons to do this. So what were the reasons that I got into emergency medicine? We touched a little bit on it, the diversity of the patients, how you don't forget anything. So, if you also specialized, like for example, a retina specialist. Now, I have nothing against them. They're amazing. They're absolutely necessary. But that's all they do. And so when they did their OBGYN clerkship, not a lot of that knowledge is going to stay or remain. Excuse me. But for emergency medicine, you have to remember that. There's some biochem that might make its way in. And, I'm not going to say that I remember every little tidbit that I learned in every class from med school, but you kind of pull from all those fields. And I thought that was cool that you got to incorporate all that. Other things were, EM's a nice blend of medicine and procedures. So, if you are not a huge surgical fan, which I was not, but I still love doing procedures, things like intubations, central lines, floating a transvenous pacer, suturing. I mean, something just like suturing is so soothing. And you take something that looks insanely horrible and you put it together and it looks like a work of art, and that's neat. But you take those procedures and then you balance it with pure medicine. So it's a really cool specialty with that regards. And I love that aspect of it. To get to take care of sick patients is amazing as well, right? Somebody comes in hypotensive or super short of breath, and it's up to you to figure out what am I going to do to stabilize them and what is going on. And sometimes I have to think opposite, not just figure out exactly what's going on, because I may not have the time or the resources to exactly get the diagnosis, so I may have to kind of work my other way around, which is try to rule out some of the worst case scenarios. So a person that's short of breath, I got to make sure it's not a PE or a dissection or a pneumothorax. So I kind of love that. I kind of love that aspect of it.
Yeah, I've actually heard you speak in the past about something similar to this, saying that you feel emergency medicine has kind of just taken the best parts of every other specialty and just mixed it into there. So in 2016, through Medscape, there was a 59% burnout rate, which is the highest amongst many of the other specialties. Are you surprised to hear that, or is that concerning to you?
I think a high burnout rate in any field is always concerning. And, again, in my opinion, and it's just my opinion, I think some of it may be due to it is a stressful job. You know, when I walk in, you're going to start working, and you're going to work until your shift ends. So there's not much downtime during the day, and you're going to have to make a lot of decisions with limited amounts of information. I can imagine if you keep doing that, and day in and day out, you got to do that, you can get pretty tired. I also, have the analogy: if your favorite flavor of ice cream is vanilla ice cream, and if I make you eat vanilla ice cream every day for the next 90 days, on the 91st day, if I ask you, do you want vanilla ice cream, you're probably going to say no. And you're going to actually probably ask for chocolate ice cream, right? So anything in life, if you keep doing it and doing it and doing it, sometimes you will get a little tired. And, and that's why I think for emergency medicine, it's not a bad idea to get a niche, a little area of emergency medicine that you're passionate about, that you make your own. For me, it was medical education. And I think that's why I don't feel like I will get burned out in this field, because I have an area in emergency medicine that I'm super passionate about that keeps me just kind of motivated. I think if you just are putting your nose to the grindstone and you work shift after shift after shift after shift after shift, I can understand why burnout happens. And you toss that onto what we mentioned before, a stressful job. I think I can understand. And then finally, the reasons why someone got into this field, I think, contributes to this. If you step away from it and someone says, oh my God, emergency medicine, they just work shifts, and they have a lot of days off, and I can easily do that. And you look at kind of like lifestyle, and you use lifestyle as a reason to get into this field. Once you get in, after a couple of years, you can easily burn out because you didn't get into this field for the right reasons. You don't realize if you work a night shift, you're using up 2 days of your life. It's not just one day or that time period.
The surrounding days as well.
Exactly.
And just a quick follow-up on this. Are residency programs taking measures to help prevent burnout for this? Is this currently something being pursued by residency programs?
Absolutely. There's a huge movement for physician wellness. And, a lot of it in emergency medicine, we talk to our residents about, your sleep. How do you protect your sleep is a common talk that we give. Food, eating-wise, right, your diet plays a huge factor into this, and exercise obviously also does. So, we have lectures, we have seminars on this. Our residents go to national meetings where this is talked about as well. So it is important, and not only at the resident level. I have to say it's stressed at the attending or faculty level as well. Every person does it differently. Some people only need 5 hours of sleep, some need a little bit more, and you have to figure out where you lie and then kind of make sure that happens. Exercise initially for me, I got to be honest with you, when I first started out, it was something we didn't really consider. But, or it wasn't important to me, I should say. That's probably a better word. And then I soon realized I needed to incorporate it into my work week. And now it's just something that's natural. And those are some things I think that'll keep you healthy and prevent that burnout.
Yeah. And do you find that there's different coping mechanisms between the residents and attendings, or how is it different in emergency medicine when you're a resident versus an attending physician?
So I think, once you become an attending, life happens, right? You may now settle down and you may get a house, you may get pets, you may have kids. So there's different mechanisms there, right? So if I go home right now and I'm stressed out, I have a couple people at home that can help me unwind and get me back into a clear mindset. Sure. As a resident, again, if you have that support system in place, it's awesome. Many residents are usually single, and so that then they'll rely on each other, and I think you'll see that where they kind of go as a group, and you do build lasting bonds. I mean, I'm still very close to people I went to residency with, and we try to get together, and we're always rehashing obviously some old residency stories, but we'll also talk about some things that happened at work, whether it be the very cool case that you saw, or what would you have done in this situation. So, I think if you try to kind of parse it out between residents and faculty, I think the residents probably utilize themselves. They always have the faculty as well. And in our residency, we actually have a faculty mentor for every resident so that they can always come to us with issues. But again, I think it's probably natural for them to utilize each other. And then I think once you become faculty, again, I also have the ability to go to any one of my own faculty members for support. But then I think your family and obviously your friends will play a bigger role, I think, as well.
It sounds like you've really got a solid brotherhood and sisterhood that kind of develops in this setting. You were talking about finding a niche. With regard to fellowships in post residency, are they necessary in emergency medicine?
I don't think so. Again, just my opinion. It really depends. Actually, I'll take that statement back. It really depends on what you want to do. So, for example, if you want to go into academics, I think more and more academic places are looking for fellowship because you are providing them with a subspecialty training. So, for example, let's say you do toxicology. You now bring something to that program, a little niche that maybe might be lacking for that program. So I think in academics, more and more places are looking for fellowship-trained physicians. For the community, it's not necessary, but I think it really goes back to what you want to do. So if you're super interested in tox, ultrasound, then you should do a fellowship in that, because that'll make you happy. That'll be kind of like your area of expertise. And also it could be an avenue for you to further develop in emergency medicine. So maybe you go to a place and you develop your own ultrasound division in emergency medicine. Or you're the person in that region that's the toxicologist and you help run maybe toxicology grant rounds. So it really comes down to your interests. Fellowships in emergency medicine are really wide and varied, but it's not a necessity. You do not have to become fellowship trained to go work in an emergency department. I think it really comes down to what you want to do. I think, again, in academics, they are kind of maybe looking for more fellowship-trained physicians.
Yeah, it definitely seems like in like you're saying, in other fields, it's a bit more necessary to get these fellowships. You're talking about toxicology for a second, and I just wanted to briefly speak about the opioid epidemic that's currently happening in the U.S. According to the CDC, 91 people per day die from opioid overdoses, which I find to be very scary. How does this kind of factor into the face of emergency medicine changing, or the population and who we're treating? How is emergency medicine changing? And you can briefly touch on just opioid epidemic as part of that answer.
Yeah, I mean, we're on the front lines, right? So you're going to see patients that have overdosed or are in withdrawal, and now you have to manage that. So our department is no different than any department in this country, that faces this epidemic. And, whether it be taking someone who's apneic, who's not breathing, and you are able to get them to breathe again, that's one aspect of it, the medical aspect, right? But then there is a huge social aspect, right, where what do you do with this patient now that they're awake? How can we get them on a road where that's not going to happen again? And there are resources in place. We're lucky in our department that we have a social worker who can help patients that want to be helped. Now, the other issues surrounding this is you sometimes see some of the side effects of the opioid epidemic. So if someone's abusing IV drugs, maybe they're coming into you febrile and septic, and that could be because they have endocarditis, or they have back pain, and that could be because of an epidural abscess or osteomyelitis. So you see a lot of the secondary effects to drugs with cocaine, aortic dissections. So we see a lot of that, and again, we are on the front lines, and we always, our biggest job first is to stabilize the patient, and then we try to help with, with their addiction. But obviously, in an emergency department, that's very difficult. We have a set amount of time we're taking care of a patient, along with many other patients, and these patients need multidisciplinary, teams to help them out. So, our goal, we try to do the best that we can, and we try to set them up with the resources that hopefully will put them on the right path. But one thing you did mention about, I think with the opioid epidemic, one of the hard things about our job is we will see patients that are seeking opiate medications.
Correct.
No different than any other field. I know the internal medicine physicians and family medicine physicians and OBGYNs, they also face this problem. We may see it a little bit more. It's not uncommon for us to have a patient who saw their doctor says, well, I'm not going to prescribe you any more pain meds, and they come to the ER. And we're kind of like their last hope to get pain medicine. And it can be tough to look at a patient and who's kind of very, very insistent. And, it is difficult to handle those patients. But that is one aspect of your job you have to kind of get to understand and deal with.
Yeah, and from what I understand, drug-seeking behavior is a huge thing that you have to deal with in the emergency department. Do you feel that being faced with individuals that are trying to manipulate physicians into writing certain scripts or for certain drugs that will, allow them to maintain, their addictions, do you find that allows residents or physicians to become jaded in any way?
That's a great question. I think subconsciously, probably you do. It's tough, right? We want to treat every person equally. We want to give every patient the benefit of the doubt. Now, there are some things that will help us. So the state of New Jersey has a prescription monitoring program, and I think that's become very useful, that someone comes in and if your sixth sense is telling you something's fishy here, we can go to that and look, and then you can see, oh my God, they got a prescription for Vicodin 2 days ago, and they're here in our ER asking, that they've not been on pain meds. So, we try not to judge anyone on face value. We try to give patients the benefit of the doubt, but again, we do listen to our instincts. We do listen to the sixth sense, and you don't want to just keep feeding the habit. I think that's the key thing. The easiest thing in the world would be to write the prescription. It's easy on everybody. It's easy on your nurse. It's easy on you. Patient gets what they want, right? But it's not the right thing to do. So you have to kind of, make the judgment call. And then look, there are people that have legitimate reasons to be on pain medicine. If you have stage 4 lung cancer or mets to your bones, that has to hurt,
I'm sure
right?
It's painful.
So, each situation is different and unique. And as an emergency medicine physician, you have to kind of judge each situation and then make the right decision. And not cave in. Like we talked about, giving the prescription is the easiest thing, but it may not always be the right thing to do.
Yeah. So if we could transition from a slightly depressing topic, what are some of the funnier or entertaining stories or some lighthearted things that you've seen that may be interesting to our listeners?
Well, I think you're going to see some of the craziest things, injuries that'll happen. Where patients could be on their roof in a middle of a blizzard. Maybe they're trying to get the Christmas lights off and they slip off the roof and fall. And you're like, why were you trying to change your Christmas lights in the middle of a blizzard? Or any number of situations. You can't make stuff up. I always tell people we have some of the best and most interesting and entertaining stories at parties because of that. Things happen. People will do crazy things, and they'll come to the ER for that. So. Whether it be they're hammering together a cabinet and they got distracted accidentally, they put the nail accidentally through your hand. They're coming in with the board still nailed to the hand, and that
props.
And most of the time the patients themselves are kind of laughing with you, and that I think that is the neat thing. One thing that is cool about our field is that you see these funny and amazing things, and you're able to kind of connect with patients you've never seen before, and then sometimes do some insanely invasive things with them. And I think that's the fun part of our job.
Do you think this is part of what makes emergency medicine so attractive? Is the unpredictability of what's going to walk in, the shift work? Do you think it's for the new generation of doctors? It seems like it's becoming more competitive in these days. Mm-hmm. What do you think is making it so much more attractive?
That's a good question. EM, absolutely. The residencies are becoming more competitive. If you look at the NRMP data, it'll show you a steady uptick in applications with regards to step scores and clerkship grades and other parameters. Maybe I think could be because we get to see a lot. The diversity of the cases that walk through the door, procedures are prevalent in this field. I think some people do like shift work. I was not a 9 to 5 kind of guy. I recognize that. I kind of like working different hours, and I love the idea that I don't have a set schedule. That you never know what's going to walk through the doors. Every shift's different, and that just makes it more fun. So I think some people really like that. Shift work is not for everyone. I have to stress that. That can be another reason why people may be burning out, is if they get into this field and they swiftly come to the knowledge that, wow, I don't really like shifts. So with respect to emergency medicine, you have to realize that ER has to be covered 365 days, 24 hours a day, right?
Yes.
So someone has to work Christmas. Someone has to work Thanksgiving. Someone has to work on a weekend. And for some people, those are invaluable times. You know, maybe your whole family gets together on Thanksgiving and Christmas, and you want those off. Well, I'll give you an example. I mean, this year I got Thanksgiving off and I spent time with my family, but I had to work Christmas.
Yeah.
You know, you have to. It's just
Can't get both.
You can't get both, right? And you're going to work weekends, and you know, guess what? The rest of the living world is off on the weekends, and they do amazing things and fun things on the weekends. And you know what you're going to be doing?
Just follow it on Facebook.
Yeah, that's correct. But you know, it's tough when you're the person that's working in the ER and working hard, and in the back of your mind, you're like, man, you know, I know those guys, those jerks are having fun while I'm working really hard. So some people are okay with that, or you get used to it, and other people, it's a hard thing. One other thing is, as you get older, and if you have kids, your weekends become much more precious. I mean, you know, especially if your kids are doing school activities or after-school activities, right? So now the only time that they're really off are on the weekends. Well, if you're working, you may now have like a 2-week span where you really didn't get to spend a lot of time with your kids. So I can understand how that can be tough on some people as well.
Yeah, I can see how that's difficult, you know, as, you know, having a family. And how long are the shifts, and how many days does a typical, you know, attending or a typical resident work in a month?
So, you know, this will vary across the country because some residencies may have 8-hour shifts or 9-hour shifts or 12-hour shifts. I would say 12, generally speaking, is the maximum hours on a shift. A regular typical shift is probably 8 to 9 hours, but again, anything in between, there are 10-hour shifts as well. The number can vary. I would say, you know, on average, you could be working 4 to 5 shifts a week as a resident, and most residencies, I think, probably have like a stepwise process where as an intern, you work the most shifts, and then you may come down a shift per month as a second-year resident, and then so on. You know, the hours-wise, if you calculate the total hours, it's nowhere near like some of the really heavy hour-intensive residencies like surgery, where surgery is probably, a surgery resident's probably going near 80 hours a week. I would say EM residents are probably going around 60 hours a week.
Yeah, I think neurosurgery is actually the highest from what we've seen. What is your opinion on the removal of the potential removal of the 16-hour cap for interns?
I mean, for emergency medicine, when they're working the ED, it has no effect. Because again, max shifts that I know of are 12 hours. So that 16-hour rule really doesn't affect ED residents in the ED. Now, where it affects them is when they go off service.
Right.
So if they're working on a trauma service or cardiology or in the medical ICU, that's where it will affect.
The longer shift.
That's where the rule will affect. And I think it's a fine balance, right? We talked about physician wellness earlier.
Yes.
You know, you have to balance physician wellness, patient safety versus education. So I can see some people argue, well, you know, if you cap them at 16 hours, they could miss out on some amazing cases and interesting cases. Or patient continuity doesn't happen. You have a lot more sign-outs, and sign-outs can be dangerous. So I understand that aspect, but I also understand the aspect of a bleary-eyed, you know, first-year resident who's just worked 24 hours and can't think straight. So I don't have a good answer for you. I think it has to be a fine balance. Again, everything has to be considered: physician wellness, patient safety, and education.
Mm-hmm. I feel like we're really hammering this home about the shift work, but it's very important because it's something that you may be doing for the rest of your life if you choose this. Mm-hmm. How do you find that you cope with transitioning from days to nights and nights to days?
Yeah, I think we all do this differently. Again, you have to know yourself to really know how to transition best. I think the day to night transition is probably pretty easy. So if I'm working a 7 a.m. shift and then the next day I'm going to work at 4 p.m., I don't think there's much. Maybe I'll stay up a little later and then wake up a little bit later the next day. The hardest turnaround is the night to day. And I think it gets harder as you get older. You know, I definitely feel it now, and I know some of my peers who've done in this even longer. They tell you it is a hard transition to make. So you know, I think for me personally, I know I have to get a few hours of sleep before I walk into my overnight. You know, there's no way I can stay awake for the entire day, go work an overnight. So I will protect myself. I will try to get a couple hours of sleep, go into my overnight shift, and then when I get back home, I usually sleep for an hour or two if I can, and then wake up. I try to function. It's hard. You feel really weird and disgusting. And but some things that help are actually exercise. This seems like the last thing you want to do. You feel groggy, you're tired, but just getting that adrenaline pumping and just getting a little sweat actually seems to put you in a better frame of mind. I'll stay awake for the rest of the day. And what I find is around 9 o'clock, I'm about ready to hit the bed, and it seems to kind of reset myself. So the next day I wake up and I can now function back on the day schedule. But again, everyone does this differently. I'm very lucky. I can sleep pretty well. No matter the environment, I can find some sleep. But some other people, it can be a little harder. So you just have to figure it out. And there's things you may have to do, like put in blackout shades so that no light gets through your window, right? Remember, you're sleeping when most people are working after working an overnight. So at 9, 10 in the morning, you need to be asleep. You can't have daylight coming in through. You need a dark room, a cool room, a quiet room to sleep. So you got to figure out a way to make that environment happen.
Yeah, and I can see it. Obviously, it's very important to function because, like you're saying, it's a high stress environment constantly when you are there. So if you're ill prepared and not physically fit, because you're lacking sleep, I can see how it may be much more difficult to handle the position.
And also, you have to be very careful not to use like alcohol as a means to get to sleep, or sleep aids. I think if you need them, fine, absolutely. But again, you want to be careful. So you just got to figure out how you can get to sleep the best. And but the worst things you could ever do is like that old adage, like, I'll have a drink before I go to bed and then I'll stay asleep. That's something you definitely want to stay away from.
The exercise definitely sounds like a great recommendation, though. I'll have to try that one day.
Absolutely.
Earlier we had mentioned that 2016 Medscape report, and another statistic that they had was that only 44% of emergency medicine physicians say they would choose the same specialty again, which was one of the lowest out of the specialties. Why do you think that is?
Again, this might go back to people getting into it for the wrong reasons, or they had the wrong expectations of what we do. It is not the amazing glamorous TV shows where there's sick people on fire running in every 5-10 minutes. We do see a lot of primary care stuff, and there's some mundane stuff we have to kind of deal with, and if you have to be okay with that. The other things are, like we mentioned before, I think finding a niche helps stave this off. So if all you do is just see patients after patients after patients, again, it is a stressful environment. You're going to work really hard. After a while, I can easily see how that can dig into you. So I think get into this field for the right reasons, and then I think carving out a niche will help you. I think it'll help you a lot, and it'll make things fresh. And then periodically, maybe you change tack a little bit. So maybe all of a sudden you're like, I really want to get good at ortho injuries, and maybe that becomes your thing. And then 5-6 years later, maybe it's like GI emergencies is your thing. Whatever it may be, but just find something that you can get really passionate about, and I think that'll help you keep going. If all you're doing is working shifts, if your goal is like, I want to retire when I'm 55 or 60, and you're going to work insane amount of shifts, I think you're going to get burned out.
I hear you talking a lot about being driven by passion, which I admire greatly. Do you find that this field has made you feel personally fulfilled? Have you ever faltered and thought maybe you've taken the wrong path?
I think everyone, no matter what job you have and what job you take, I think you're always going to have thoughts. Did you pick the right field? But I gotta say, I can't imagine doing anything else. This is just seems like a perfect fit for my personality, for what I like to do, and I think that's the acid test, right? If you can see yourself doing something else, then you almost have to question why not just do that. But I really can't see myself doing anything else. I don't know what else I would do. This just seems to be the right job for me.
Yeah, I'm glad to hear that you feel that way. Mm-hmm. So we just have a funny question. We were talking about these TV shows where people come in, running on fire. Do you feel like there's any accuracy, or do you feel like there's a lot of appropriate representation of the medical community in this?
Obviously, I think the TV shows will dramatize it a bit more. But we do see some amazingly sick patients, some incredible, amazing patients in trauma accidents that will come through our doors. So some of the cases are based on what we do. Sometimes some things are go a little overboard, I think, on TV. But
Yeah.
yeah, we do see some interesting cases, a wide variety of cases, and a lot of sick patients. So they obviously make it feel like the entire shift is like that, and I have to stress that not every shift is, wall to wall craziness and insanely sick patients.
Mm-hmm. And if we were to look a bit to the future, where do you see our field in 10 years? There seems to be some competition with nurse practitioners and telemedicine, kind of like Skyping in to speak with medical professionals. What are your feelings about job security for emergency medicine in the future, and where do you see the field in 10 years?
With regards to job security, I think EM has really good job security, right? People are always going to have heart attacks. People are
Right.
always going to, have accidents. People are always going to get sick. It's just the way of the world, right? So we are there to be in those situations. So if you wake up 2 in the morning and you have, crushing chest pain, you're diaphoretic and short of breath, that's why we're there. For you to come in, for us to diagnose that ST elevation of mind and get you the right treatment. If you happen to be in a car and all of a sudden someone hits you on your side, that's why we're also there, to kind of stabilize you and figure out what's wrong. If I look at just our ER in itself, the census of patients has kept going up and up and up, and most emergency departments, I think, have seen that uptick. When you look at some stats, the number of emergency rooms has actually decreased over the last 15, 20 years.
Really?
But the patient visits have gone up. So clearly we're needed.
Yes. I see.
Mid-level providers are absolutely needed in the ED too to help us, right? I don't think, if you're going in the EM that you need to be worried that you're going to lose your job. The other thing about our job is we are kind of like Swiss Army knives. You can put us in any type of environment, any setting with any resources, and we'll figure it out. We'll function somehow. So if you like to do international health, there's no better field than EM to get you into those situations and sites. To practice like austere medicine. Wilderness medicine is a great example.
Yeah, I've seen some people practicing.
Yeah, and then there's other avenues for emergency medicine physicians. Administration obviously is becoming a huge thing, where more and more hospitals seem to want physicians in some of those admin positions. And I think EM lends itself towards that because, one, we work shifts, so we can make our schedules flexible and get involved with admin. 2, all day long we make decisions. And, as an administrator, that's what you got to do as well. So we are really good at looking at where the risk benefits to a decision, and I think that might make us attractive to working in an admin. Other situations like urgent care, you're seeing EM physicians getting involved there. But I can't see us, getting phased out. I just think there's so many things that we can do, and our skill set is such varied that I think we're always going to be around.
Mm-hmm. It's good to hear that we've got some job security here. Mm-hmm. No more robots, automating our services. As we begin to wrap up the conversation here, what was some of the best advice that you received from a mentor going into residency or when you're applying to residency for emergency medicine?
It's a good question. I think, you find you don't always just have one mentor. You find you have a lot of mentors. And, some of the advice that I got were, to do the field for the right reasons, and to understand it, to understand what are the pros and what are the cons. There is no one job that's perfect, right? Because if it was, we'd all be doing that job. So everyone's different. You have to do a field because it fits your personality, it fits what gets you interested, it fits what makes you excited to do that job. So I thought that was important to hear, that there is no perfect job out there, that there are warts on every job, and you just have to figure out if you're okay with those warts. And then more importantly, are the highs of that job get you super excited. The other advice I got was with regards to emergency medicine was, you have to understand that there's going to be some times where you can do everything right and you can have a bad outcome. Mm-hmm. And that was good to hear because we all, I think, want to do the best for our patients, and then you could do everything right, and then sometimes no matter what you did, there was just a bad outcome. And it was good to hear that. It was good to understand that can happen sometimes, that we have the best of intentions. That doesn't always mean that the best outcomes will happen. And then finally, I think the other advice that really has helped me out is that don't lose track of the things that make you you and that get you excited outside of medicine. So, whatever it is that you love doing that's not medically related, you should still kind of keep doing, and you can't just become a medical, robot and just every day, every ounce of, living light, you're going to just study medicine. And, there has to be another outlet and something, whatever it is that makes you you, you still have to continue to do that.
Mm. And just to hit the alternate side of the spectrum, we've just discussed the best advice you had received. What do you think is the best advice that you did not receive? What is one thing that you feel would be the most important that you wish you had known before going into emergency medicine residency?
There's like subtle things. Like one, you don't realize how decision fatigued you can get at the end of a shift. All day long you're making decisions. And then, you get home and people will start asking you questions and all you can keep thinking about is, I don't want to make another decision. I want somebody else to make the decision. Yes. So, and that's something where over time, you just talk to your loved ones, you just let them know, like after a shift, hey, listen, if you, wherever you guys want to go to eat, I could care less. And not for them to get upset, not for them to think like, oh my God, he doesn't care. But that was just something I think over time I kind of figured out myself that, oh my God, when I get home after a shift, I really don't want to make a lot of decisions. So I think that was something I wish somebody had kind of let me know about in the beginning. And then to talk to me about really how important it is to develop good interpersonal skills. I think everyone assumes you become a doctor that you become a great teacher, you can communicate with everyone. Those are two skill sets you got to develop. And I think both are essential in emergency medicine. So if I could give any advice, it is that if you're going into emergency medicine, work on how to teach. You're always going to teach someone. You may be teaching your patients how to take medications, how to eat better, how to follow up, whatever it may be, teach colleagues a procedure. And then, it's just one of those things where communication is essential. It is what we do. So that is, and it's a skill set that can be developed. You don't have to be the most amazing communicator ever to go into this field. You can develop that skill. You can develop how you talk to someone that just, there's a devastating outcome, how you talk to family, or, how do you break bad news? Those are skills you can develop. So those are two things I'm sure someone had told me about it, but maybe they hadn't stressed it, and that would be something I would stress.
Yeah. So it seems like you've got a lot of great advice for all of our students listening. And just our last item that we're going to ask you about is, what resources do you recommend for students interested in emergency medicine residencies? That's
a great question. I think there's a lot of good resources out there. If you're thinking about going into emergency medicine as a field, I would point you to a lot of different resources. There's www.emra.org. That will show you some of the things, kind of give you a guideline in terms of what to do if you're interested in EM. ACEP, that's the American College of Emergency Physicians, .org also has like a residency catalog and a visiting student catalog and other resources for students. SAEM.org, which is the Society of Academic Emergency Medicine, has a great website as well. AAEM also has a great website. And then there's one that I'll highlight, which is www.cdemcurriculum.org. And the CDEM is the clerkship directors of emergency medicine. That one shows basic approaches to common complaints that show up in the ED. Then there's specific information on specific disease processes. And there's also links to good resources there as well. So there's plenty of good resources out there, but those are, and I'm sorry, I'm probably missing a couple that are amazingly good, but those are
we can list them in the comment section
perfect. Below. Just some off the top of my head that I can think of.
Yeah. Well, I'd like to thank you again, Dr. Patel, for coming in today and sharing your experiences and your lifelong commitment to emergency medicine and teaching students.
Oh, thank you. Thanks for having me.
Thanks again. Now, at this point in our podcast, I'd like to welcome back my colleague Kyle for the statistics portion of our program.
Thank you, Justin. That was a really informative interview. I think Dr. Patel sold me on emergency medicine.
I totally agree. He definitely inspired me to consider emergency medicine as well. After looking at some of the stats you provided, can you speak a little about your findings?
Well, the 2016 National Resident Matching Program said the average USMLE Step 1 score for U.S. students was 233, And as we know, the average Step 1 score was 230, so that's just a little bit above the average. And just put that to more context, if a U.S. graduate has a 220 Step 1 score, they had about a 90% chance of matching into emergency medicine.
And I was also looking at some of the data you had for osteopathic schools. For those taking the COMLEX Level 1, the average was 593. In addition to that, I was also looking at the U.S. international medical graduates. Can you tell me a little bit about those scores?
Yes, the U.S. international medical graduates, they had an average Step 1 score from about 235, and that's for match applicants. You know, on previous episodes, we saw that if you're a U.S. IMG, you need to have a higher score than your U.S. counterparts.
Well, for Step 2, U.S. seniors had a score of 245, and U.S. IMGs had a score of 242, which seems kind of funny because for Step 1, U.S. IMG students typically have to have a higher score, which seems to be the trend in some of the other fields we've been looking at. But for Step 2, U.S. IMGs had a lower score on average.
It seems pretty close, 245, 242. Let's call it a wash on that one.
I agree. And for osteopathic students taking the COMLEX Level 2, a score of 610 was the average.
You know, one stat that really caught my attention is the number of abstract presentations and publications needed. 429 match students had 5 or more. Now, if you're thinking about me, I don't have any research, so I'm worried, do I have enough to match? But then I saw that 298 students who matched had no research.
And what did you find in regard to the overall match rate?
The overall match rate was 88%. Just put that in context. 1,486 matched out of 1,693 U.S. seniors. For U.S. IMGs, they had a little bit lower, below 50%. It was 46% match rate.
And during the interview with Dr. Patel, we spoke about training and the hours. Could you tell us a little bit more about what you found?
Well, training consists of 3 or 4 years of postgraduate education, depending on which program you go to, with the average hours worked per week at 46. With those hours and the idea of shift work, it's no wonder EM is one of the fastest rising specialties in the new generation of doctors.
Another interesting fact about the compensation, which is making this a very fast rising specialty, is that according to Medscape's 2016 physician compensation report, emergency medicine physicians make an average of $322,000 a year.
That's the same as surgery.
I remember that from the episode we did last time for the surgery. And for fellowships, Dr. Patel was also mentioning a few things.
As we heard from Dr. Patel, fellowship is not a must for emergency medicine, but they do have some interesting ones. They have fellowships such as disaster, tactical, and wilderness medicine. They have fellowships just for ultrasound training and for toxicology.
According to Dr. Patel, passion was something he spoke about a lot. And according to the 2016 Medscape Lifestyle Report, only 44% of emergency medicine physicians would choose the specialty again. That means the majority of physicians would choose a different specialty if they had the chance. That's pretty interesting.
Well, I think it goes back to what Dr. Patel said, that you need to choose emergency medicine for the right reasons. And the hours look great, and then the compensation looks great, but you gotta love it. You gotta make sure that you're able to wake up every day and go for those emergency medicine shifts.
I agree, and I'm glad we had this experience with Dr. Patel. Thanks again to all of our listeners for tuning in to the Emergency Medicine edition of Specialties in Medicine featuring Dr. Sundip Patel. If you appreciate what we're doing at the SIM Podcast, be sure to like and subscribe. Also, let us know in the comments what other specialties you would like to be represented, because when all is said and done, we do this for you. See you next time. This is Justin.
And Kyle.
Signing off.